بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. كل عام وحضراتكم بخير. عيد سعيد. أمسية علمية جديدة من سلسلة Egyptian Flying Spine Surgeons. يسعدنا النهاردة وجود الأستاذ الدكتور باسم جورجي وماي كوتشير بروفيسور دكتور يسري الهواري. كل سنة وحضراتكم طيبين. دكتور يسري اتفضل يا بيه.
Dear colleagues, it gives me great honor and pleasure to introduce my dear friend, Professor Bassem Georgi. Professor Bassem was graduated from Cairo University, Qasr Al Aini Hospital, and we are very glad to have a flying surgeon from Egypt and practicing neuroradiology in University of Southern California, San Diego. Professor Bassem was the past president of the American Society of Spine Radiology. He is also a past president of San Diego Radiology Society. He has written chapters of many books. He has joined us in the Aging Spine meetings, 8 meetings now for 8 years. He's one of the pillars in these meetings. He will come all the way from San Diego, half the circumference of the hemisphere, to attend and give us his lectures in this meeting. هو بصراحة أجدع واحد ممكن تلاقيه على وش الأرض، يعني مش عارف أترجمها دي. باسم, thank you very much for joining us in this webinar, and please give your talk on the 3rd generation vertebroplasty. Thank you, Bassem.
Thank you يا دكتور يسري. يا ترى كل الناس سامعيني دلوقتي؟
Yes.
اوكي.
اتفضل يا دكتور باسم، سامعين حضرتك.
شكرا يا دكتور يسري على الانترودكشن الجميلة دي، وشكرا يا دكتور محمد على تنظيم الويبينار دوت. والحقيقة يعني أنا طبعا كل سنة وانتم طيبين كلكم. والحقيقة أنا عايز أقول لكم يعني إن أنا الميتنج الايجنج سباين ده أحسن ميتنج بحضره كل سنة، لأن فعلا بتعلم منه حاجات كتيرة قوي. إن شاء الله أكلمكم النهاردة عن موضوع جديد ابتدى يعني يظهرنا كتير في أمريكا، وهو الثيرد جنريشن فيرتيبروبلاستي. طبعا ثيرد جنريشن علشان الفيرست جنريشن
English. We have foreign audience.
English, please.
Okay.
Thank you.
So the first generation of vertebroplasty is the standard vertebroplasty that we all know. The second generation vertebroplasty is the kyphoplasty and all the different cavity creation devices. So the third generation vertebroplasty is when we do vertebroplasty and placing some kind of implants inside the vertebral body with the cement. So this is going to be my subject today. This is my disclosures, and we're going to have an overview of the different vertebral implants available in both sides of the Atlantic, because what's available in Europe is not available in the United States. We'll summarize the common features, and then we'll discuss the future trends of vertebral compression fractures. So there is 4 types of implants that's now available in the market. The OsteoFlex, I think this is out of the market now, so we go down to 3 different implants. The Kiva, which was the first one that was approved by the FDA in the United States, and the vertebral body stenting or stentoplasty, which is available in Europe probably now 7 or 8 years by DePuy and Johnson & Johnson. And then the last one is the spine jack, which was designed by a French company called Vexim, and then was bought by Stryker. So the Kiva and the spine jack are the only 2 available in the United States. The vertebral stenting is the one that's available in Europe, and also they have spine jack and Kiva. So let's start with the Kiva. The Kiva was a company called Benvenue, and it's bought 2 years ago by another company called IZI Medical Products out of Canada. So it's a very smart implant, and the guy who designed this one was actually the one who first designed the GDC coil that goes into the aneurysm in the brain. So it looks like a coil when you look at it. So the way it works is you have an access device that goes inside the vertebral body, and then you have a nitinol coil that comes out of the device. And then once you deploy your coil, you advance a PEEK implant over the coil. And this PEEK implant has holes inside, but not outside. And this is the final shape of the PEEK implant. Once you have the PEEK like this, you take the nitinol coil out and then inject cement so the cement stays inside the center of the PEEK implant. So this is the X-ray picture. This is the nitinol coil, and this is the PEEK without the nitinol, and this is the final cement AP and lateral view. So this is just a typical case. The patient had a fracture that was treated and have a new fracture here. This is a STIR and T1 weighted images and the CT examination. And step by step, if you notice that when you go using this type of implant, you have actually to go a little bit more lateral and superior, which is different than the actual technique that we use for vertebroplasty. You usually like to go more into the center, but this one you have to go in the superior lateral aspect of the vertebral body. So when you put your implant, it will rest in the center of the vertebral body. This is a unipedicular process. So this is the access device. This is the PEEK. I'm sorry, this is the nitinol coil. This is the dark one is the nitinol coil. When we took the nitinol coil, this is the PEEK implant, and this is the lateral view, the AP view, and this is the cement after it gets injected inside the center of the PEEK. So there is a lot of studies, and the big study was called the CAST study, and this is a study that they actually compared the Kiva to the balloon kyphoplasty, and this is how they got the FDA approval from in the United States. Study has very good numbers. Go back that the study basically established that Kiva is a non-inferior to the balloon kyphoplasty. So this was a non-inferiority study. There was no side effects or any complication from the device. Pain level was very good in both types of procedure, kyphoplasty and the Kiva. The bone cement, the amount of bone cement as you expect was lower in the Kiva. And one more interesting finding that the adjacent level fractures was much lower in the Kiva cases, and also the number of leakage of cement was much lower in the Kiva, of course, because you're using less cement. Multiple other studies confirmed this finding. So this was not just one study. There was was confirmed by multiple other studies. So in summary, the Kiva showed us that there is definite decrease in the rate of adjacent level fracture, which is one of the big complications. It improved the kyphotic angle restoration. It reduces the rate of cement leakage, and of course, the amount of cement volume. And the pain level and the function restoration was almost the same like the kyphoplasty. The question came is why we have a reduction in the rate of the adjacent level fractures in the Kiva patients compared to the kyphoplasty, and you can see the numbers here. And the reason is probably because the Kiva, because it's a PEEK, it's a little bit less stiff compared to the cement alone. And remember that you're using less cement with the Kiva. So that may be a reason why there is less adjacent level fracture. So remember that the PEEK is a good friend for the spine from our experience with surgery compared to the cement. Now we come to the second one, which is the spine jack that was designed by Vexim and then bought by Stryker, and Stryker was able to get it into the United States about 1 year ago. Actually 1.5 years ago. So the way it works, it's exactly like the car jack. That's why they call it the spine jack. So if you imagine El Correc in your car, it works exactly the same. So it goes inside the vertebral body compressed or undeployed, and then you move it, you deploy it from outside, and you open the spine jack, and you have the end plate. You have the two upper and lower plates that move up and down until you have a maximum height restoration, and then you inject cement around the spine jack. They come in different colors, different sizes. It's interesting that the actual lens here is not different from the bigger size to the middle size. I start using the middle size all the time, and then I move to the bigger one because the lens is really about 3 or 4 millimeter difference, but the larger size will give you a higher maximum expansion rate compared to the middle size. That's why I like it, because it can give me more height restoration. Typical case, this patient was a 48-year-old. Remember, this is a young patient, traumatic fracture. It's an L1, had pain for 6 months, and pain never went away. It was compressing and getting a little bit worse over time. And you can see there's about 40–50% decreased height. And we did the spine jack. So the way it works is you have to have some kind of a drill to make a track for the spine jack, and then you put the spine jack, and then you start deploying it slowly in the AP and lateral view. You can see that the end plate is getting raised over time with the more you expand the spine jack. And then you put the cement in the AP and lateral view, and this is how it looks like in the final images. So again, a lot of studies. The biggest study was this SECOS study, which was actually multi-European study for about, I think it was 14 countries in Europe. And this is the study that the Stryker was able to get the FDA approval here in the United States. The study was 5 countries, 13 sites, 15 investigators. It happened that I actually know probably 14 of those investigators in a personal level. And they're all good guys, and they work very hard for that technique. Again, the results is very impressive. The pain level goes down, the disability index goes down for in 1 month, 6 months, and 12 months. The data was very strong over a 12 months follow-up. Now, one of the interesting findings in this study, again, is the number of adjacent level fractures. So if you see, those are the actual numbers, and you can see that the spine jack in 12 months period, there was 12 fractures in 8 patients compared to 26 fractures in 18 patients in the balloon kyphoplasty. That was at 12 months. The 6 months was, again, almost the same, very impressive numbers. And they did a lot of studies where basically they do a 3D modeling to look at the vertebral body before and after the spine jack by CT. So they do CT images and they do a 3D modeling, and they can actually demonstrate the height restoration that happens. The red means that there is more height restoration in the post-operative cases. Same thing when restoring the middle of the vertebral height versus the baseline here. So multiple studies. This study actually showed there was actually 5-year follow-up, which is actually a very good study to look at those numbers. And again, they showed that the rate of adjacent fracture was only 2.6%, which is almost nothing compared to what we have now with the kyphoplasty. Different studies, I don't want to go into details, but again, it shows the restoration of the kyphotic angle over 1 year. Another study, and this study was more like more into details on why this idea of restoring height or the idea of adjacent level fracture is lower than the kyphoplasty. And they thought that this is probably because this is the only device that we have that have a direct lifting mechanism. Remember, when you put the balloon, you are expanding the force over different over the sphere of the balloon, but the spine jack, all the force is going up and down towards the end plate. Now, having said that, I just want to show you a case of failure, and I like to show the cases that doesn't work right so we can learn from it. So this patient, I had it actually like 5 weeks ago, 55-year-old woman. I think she weighted, I think 350 pounds. So it was almost the weight limit for the table. She's diabetic and have sleep apnea. So the surgeon, and this was a traumatic fracture, and the surgeon asked me to do a spine jack for it because especially now we're trying to do more spine jack in the junctional zone between the thoracic and lumbar spine when you have fractures like T10 down to L2. And because it's multiple levels, 3 levels, and I just want to show you here in this image how much fat she does have in the back. All the white stuff in the MR is fat. So I was not able to do a spine jack in this case because I did not have enough space for my handle for the spine jack when I was doing the patient between the patient back and the X-ray. So I end up doing just a routine vertebroplasty, as you see here, and this is the post-CT images. Now, what happened is this is the standing view 2 days later, and you can see this is a very bad angle for this case. And this was the CT. The angle here is better in the CT because the patient lying in her back, but standing, the angle is exaggerated. So the surgeon had to take her and did a fusion 2 above and 2 below. So this is a case where I think maybe a spine jack will be helpful here. I don't know, but technically it was very difficult. But after this case, now I am any case that if I will have a case like this and I think that I'm not doing spine jack or I'm only able to do a vertebroplasty, I will not do it and I will have the patient goes direct to surgery. So that was a learning experience for me from this case. So summary, again, there is less cement with the spine jack, less leakage, there is less adjacent level fracture, and actually the papers, I didn't mention that there is a couple of papers or 3 papers that shows actually that the pain control is maybe even better than balloon kyphoplasty in the spine jack. Now, the most important finding here in the spine jack is that the height restoration and maintenance of the height restoration over a long time. So we have seen a lot of cases of kyphoplasty where after 1 year or 1.5 years or 2 years, you can see some decrease in the height, or sometimes you get a height restoration when you inflate the balloon, but once you deflate the balloon, you get the height back. But here, the most important point here is that the maintaining of the height restoration compared to balloon kyphoplasty. Now, the third one, which we don't have a lot of experience in it in the United States, is the stentoplasty by Sensus at the Pew. And again, it's a very simple procedure. You put a stent in, and then you inflate the stent with a balloon. And then once you inflate the stent, you put cement inside the stent, and your access device leave, and the stent stays in with the cement inside it. Works very good for decreased leakage. Again, a lot of papers, but the papers actually had some issues with the technical aspect of the procedure, because sometimes they said that the actual procedure is difficult technically because you need a lot of pressure to open the balloon. You can imagine if the bone is hard, sometimes it's very hard to open inflate the balloon against the pressure. So there was some complication in the early cases, but I think that the balloons that they have now and the stent they have in the market now is actually working very good, and I will show you later on some cases. So let's go back and just summarize what I said. So the advantage of the vertebral implant that you have less cement, less leakage, there is less adjacent level fracture, which is up to 3% only with the spine jack compared to 12% in kyphoplasty. There is a question about clinical outcome, and there is definite long-lasting height restoration and kyphotic angle. Now, there is a lot of talk about treating burst fractures A1 and A2 and A3 and even A4 with even retropulse fragments with the vertebral implants. And this is where we actually going on now in the United States and Europe. Everybody is pushing towards the traumatic burst fracture for treatment. Now, there is a lot of disadvantages, and it's more expensive, it's more complex to use. Definitely, this is not your first case to use. It's not for every level. You're not going to do a Kiva or a spine implant for a T3 or T4. And we still, you know, even we have 5-year outcome for spine jack, still we don't have a long outcome results. So what we are trying to do here now in the United States and Europe is trying to push the technique a little bit more. You know, this is like, we all agree that this is not the patient who's 85-year-old or 90-year-old have a simple compression fracture that needs vertebroplasty. Do you guys hear me now? Well, hello.
اتفضل يا دكتور باسم سامعين
Okay,
حضرتك.
can you hear me good?
Yes.
Okay.
Yes.
Because I had some vibration.
Okay.
So we are trying to push now for using it for traumatic fractures. And I also want to share with you some cases that we are starting to use it for also malignant fracture. And this is where we're seeing those devices going on, not for the simple vertebroplasty that we all have. So let's go and we'll talk about the A1A and A3 and A4 tumors. And there is a new technique that described in Switzerland called SAFE technique. I will go through it. So I am not going to go in details into that. This slide is more for the radiologist. Treatment of traumatic burst fracture, I know it's a lot of controversy and a lot of questions in the surgical literature. But the point here that I'm trying to make is that we have a device that show us a persistent elevation of the end plates for a long time. And this is very variable in terms of the long-term outcome for compression fractures when you guys have the A1 and A2 and try to follow it up with the standing views and see if it is compressing more or not, or when you do the surgery or not. So that's the whole idea of what we have with this technique. So now we're pushing hard for the A1, A2, and A3, and some A4. I don't think it's a good idea to go to the B, the distraction type of fractures. This is all you know it, that this is not for cases with neurological deficit at all. So any of the cases that I'm showing you, this is cleared by the surgeons that there is no neurological deficit before I do anything for them. And these are usually probably on the subset of cases where they are stable with no neurological deficit. And the question is between surgery and conservative treatment. So those are the subset of cases that we are looking at to treat by the vertebral implants. Of course, this is not for the chance fracture. Chance fracture is completely different than the burst fracture. And I always like to put this slide for the radiologist because there is a big difference between this one. This is a surgical fracture. This is not minimally invasive fracture. And I'm sure all of you knows what a chance fracture is. So the first paper was from Europe, was a prospective study. This is a prospective, not retrospective, 1-year follow-up, multi-center, 108 cases of spine jack for burst fractures. The numbers was very good. They have some reports of 2 years, but we don't have it yet. And they looked at the VAS numbers and the technical feasibility and the general assessment of the performance and safety and all that stuff. And you can see here the numbers are in terms of pain, analgesic, and disability works very good in up to 24 months. So that technique definitely have some applications, giving the numbers and giving the absence of any complications. So there is a lot of talk about this. We're looking at doing a study in the United States for the burst fractures. The second point I want to talk about is metastatic disease. And this is an area that I really like, and we try to push hard for those cases. So let me show you a case. So this was a case of a 63-year-old woman with an L1 burst fracture. Now the CT was done on admission, and the MR was done the next day. So you can see that the fracture compressed about 50% in about 24-hour period. So when they asked me to do a biopsy and do kyphoplasty, in this case, neurologically, the patient was fine. She just had focal pain. And I felt that this is completely unstable, and there has to be just something more than doing vertebroplasty or putting cement. So what I did here, I did a radiofrequency ablation. Those are the Medtronic OsteoCool radiofrequency ablation, and I'm actually moving now to the Medtronic system rather than the Merit system, and I will explain to you soon. And then after I did radiofrequency ablation, the way the OsteoCool system works is it actually blasts the whole vertebra. So it just takes the whole vertebra and heat it completely, compared to the Merit system where you have to move it from one place to the other. And then after I did the radiofrequency ablation, I put a spine jack, and this is the final results in the fluoro, and this is the final results in the MR and the CT after we did this case. I wanted to look at this image in particular and see this, all this dark signal is basically the tumor that was ablated by the radiofrequency ablation. These two lines here are the spine jack artifact. They don't do a lot of artifact, but you can see that the whole black stuff is the basically tumor that was ablated and cement around it. This is another case. Again, this is an older case where I have these two lytic lesions here. And this case, I use the Kiva study implant. So I did an radiofrequency ablation, and then I put the Kiva exactly inside the lytic lesion that was in the vertebral body. And you can see here, there is very little cement applied in these cases. This is the CT axial, this is the CT sagittal, CT axial. Now, after doing that, usually the patient will go back for radiation therapy or chemotherapy based on the type of the tumor. This case, I had it about 3 weeks ago. This is a very interesting case because usually when we see a lesion like this crosses the disc space, we would think more of an infection rather than tumor. This was a proven multiple myeloma. The patient had known prostate cancer. He showed up with this lesion in the MR, and when we did the biopsy, it was a multiple myeloma. She had the prostate cancer and myeloma. And this is the axial image, and you can see the whole tumor is taking the whole vertebral body. So did the same thing I did before, where I did the radiofrequency ablation by the Merit system in both levels. I put 2 spine jacks in the one above in the 2 levels, and put cement, and this is the final results in AP and lateral view. And this is the images after, this is the post-contrast images with gadolinium after the procedure. And if you can remember how the tumor was here in the pre-procedure, and here is the tumor almost gone. There is a little bit some enhancement around the cement and the spine jack. I'm not arguing that I'm killing the whole tumor, but definitely I decrease the tumor load. This enhancement or this white signal in the post-contrast images are probably combination of reaction from the radiofrequency ablation or some tumor. The only way we can tell is we do a PET scan to see if there is any activity or not. And this is the axial imaging. In the upper level, you can see there's complete black signal. This is the tumor ablated and the cement. This is an artifact from the spine jack. Same thing in level below. Again, almost complete black, no tumor. And this is a spine jack. There is some reactive enhancement around the vertebral body, which was there before also. And I think this will be very difficult for me now to treat it. The last topic I want to talk about it, and you can look it up on the literature, that's Alessandro Sinfioni. He's really very talented guy. I can tell you that this guy is actually works, he has a poliomyelitis and he's actually in a wheelchair, but he stands in the IR suite and he works like for 4 or 5 hour cases that he does. So he came up with this new idea where if you have a tumor like this lesion here, what he does is actually he can ablate radiofrequency ablation or not, depending on the case, but what he tried to do is he put a stent, like use the stentoplasty that we have, and then inject the cement in the stent, and then he put a screw in the pedicle. So basically he's doing a 360 fusion for his tumor cases. And again, those are all cases that are not neurologically stable with no neurological deficit. And this is what he showed in some other cases. So you have a stent, radiofrequency ablation, stent, cement, and screws posteriorly. Very nice 360 fusion, and it's all percutaneous. And for some reason in Switzerland they like to do level above and level below. I don't understand why that, but that's what they do. So in summary, of course, this technique we can't do it in the United States because we don't have stents approved. Potentially can be done with a spine jack, but I'm not aware of any one of us have done it yet. So in summary, there is multiple vertebral implants available in the US and Europe. There is a lot of evidence in the literature to support the advantage of this technique over traditional kyphoplasty. There is less adjacent level fractures. There is definitely better and more maintained height restoration. There is less cement leakage and volume. There is a definite rule that we're trying to explore now in treatment of traumatic compression fractures and potentially in malignant lesions. And that's all what I have.
Thank you very much, Dr. Bassem, for your nice case. The third generation implants for vertebroplasty. May I ask you a question regarding the Kiva, Dr. Bassem? Do you think the type of cement which can be used in Kiva, like high viscosity cement which you can use in vertebroplasty, or you need less viscosity cement to be able to get rid of this cement from the narrow holes in the Kiva poly peak material?
This is an excellent question. So the Kiva, the way it was designed, if you remember how the implant looks like, the holes are very small. So you have to use actually a very liquid cement. And we had a lot of troubles in the beginning because the cement will plug and you will not be able to push all the cement. So it was technically, that's why I shied a little bit from the Kiva, because technically was actually hard to do, the technique itself. And the actual device is much bigger. I know now they have changed a lot of things in the device when the new company bought it. And I'm ready to use it again because I don't like the artifact I get from the spine jack when I do the MR. So I know that they have worked those technical issues, but I haven't used it yet. But that's an excellent question. Yes, that's true.
You know, because in some of the X-rays that you showed us, I can feel that there is really leak around the devices and the implants. Regarding the spine jack, is there is any possibility to fracture the end plate? Because it is.
This was my main concern when I start using the spine jack, and I asked, there is, just let you know, there is people in Europe, and I know Dr. Yusri knows whom I'm talking about. They have done probably like 3,000 or 4,000 spine jacks. And that was my main concern about, does it really, can it go through the end plate? And none of them have said that it did happen. I would love to have more like surface area, but it didn't happen. Now I can tell you what happened is when I do the RF. Now once you do imagine when you do the RF, you have like the whole vertebral body is like void. There is a big cavity. So I have seen the spine jack that actually can rotate with you a little bit right and left because there is nothing to hold it. So it gets very tricky that you have to hold it, superior, inferior, so it doesn't flip around. That's the only thing that I actually found in the spine jack.
Okay,
but in tumors or metastasis, is it better to do a cryo or heating? What do you prefer?
So the classic teaching is the radio frequency ablation for inside the vertebral body. When you have the lesion inside the vertebral body, if you have a paraspinal lesion or a soft tissue component, that's the cryo. It's very hard to do the cryo inside the vertebral body because when you do the cryo, you destroy the whole bone, and you cannot put cement immediately because it's very cold. So you have to wait 1 day or like 3 or 4 hours at least. So you have 3 or 4 hours where the patient has no stability or no bone in that lesion to put the cement, because you can't put the cement after the cryo. It's very cold. And the other thing is it gets very hard to see the what we call it the ice ball with the cryo, because when you see it in the edge of the bone with the CT, it's very hard to tell where is your edge. So usually what we do is when you have a case with a lesion, I have cases I can show it to you later on, where you have a lesion in the vertebral body and there is a big mass in the paraspinal muscle. We do the cryo, and then we keep the patient overnight in the soft. They do the cryo in the soft tissue, or we do the cryo early in the morning, and then in the evening we go and do the vertebroplasty and the radiofrequency if we need in the vertebral body. Or the opposite, you can do the radiofrequency and the vertebroplasty in the vertebral body and then do the cryo. And the cryo has a lot of tricks in it, because the most common actually thing that happen is when you have a lesion, you can imagine if usually extending in the psoas muscle, and you have the ureter anterior to the psoas muscle. You don't want to hit the ureter with the cryo. So you have to put a needle anterior to the psoas muscle and inject some air or fluid like saline or whatever to push the ureter anterior, and you have a space so you can do the cryo in the psoas muscle.
Okay, may we have some comments from the attendees, Professor Mazhab?
Thank you. Hello, good night. I would like to thank Professor Bassem. I hear the and you are welcome, Egypt, always. My question is about the Kiva. I understood from your presentation that there is a coil, and you just put the peak envelope around this coil. Is it right?
Yes.
Then you inject cement and keeping the coil inside. So you put the coil, the cement between the coil itself and the peak envelope.
No, you have
to. Is it right?
No, you have to pull the coil out. And then
was not clear in your presentation. I'm sorry. So now you have a space. Fine. You have the space occupied by the peak, and this was just the preparation by the coil.
Yes.
And you said the injection going to be soft cement. And my question was based on that you didn't remove the coil, so you have to put more pressure in the cement in a very narrow space. So my question now is clear. You explained it nicely that you remove the coil like the Kyphon theory before. When you inflate and remove the Kyphon, then inject in the vacuum created by the Kyphon itself. So the theory is the same. You use the coil like the kyphoplasty, like the Kyphon itself. So I understand now. Go to the other part of my question, or the second question, is the lifting of the end plate. Is there is an indication that limit the lifting up the degree of comminution of the end plate? And I understood that the end plate going to be lifted in its whole length, so you can lift up peacefully, relying in less comminution of the end plate. So if the end plate is more comminuted, can you cancel this lifting up? The number one. The second, that you said you use two lifters in the right and left, because in the beginning you have said that you used monopedicular, monoportal. You use one. So now in the tumor case you have used two. Is this technically easy to go and put, and the direction of this lifter going to be in the opposite direction? How can you manipulate these two devices through different pedicles in the same time in a case which is tumor or with destruction of the end plate? So I would like to have your answer and the explanation for this point.
So the key, okay, so the Kiva is unipedicular. So you go, as I mentioned, you have to go in the superior lateral corner, and then you drop the coil in the center. The spine jack is bipedicular. It's always bipedicular. And the way we do it is we have access in one level until you put the spine jack in one side, and then you get access in the second side, and you put your spine jack in the second side, and then you start lifting both sides together. So you have a coordinated lifting in the same time in both sides. Now, we usually would try to put the spine jack a little bit just inferior to the superior end plate, which is compressed, so we get more height restoration, or we just attack the end plate early on when you are inflating. There is a limit of inflation, which is the maximum height that the spine jack goes in. And I think it's 17 or 18 millimeter in the bigger size. Again, as I mentioned, I know there is a lot of cases where the end plate is destroyed or destructed. I haven't seen a case where the spine jack went through the end plate. The only cases I saw is the spine jack will just rotate a little bit because you want it to be straight upside down to get the maximum elevation of the end plate. But I saw those only in the tumor cases because there is no tissue, basically. But I haven't seen it in the osteoporotic cases. Did that answer your question?
Thank you very much. This is a very good explanation, and thank you for the presentation, Dr. Bassem. Nice to hear you.
Thank you, Professor Maziad. Dr. Hamdan Abdulrahman from Germany.
الو مساء الخير.
مساء الخير.
السلام عليكم. مساء الخير يا دكتور باسم بيه. I am amazing about the expansion and extension of the indications for spine jack. The first, my comment, the first indication, the first description of the technique was in 1987 by Galibart in the vertebroplasty in patient without collapse, with a need of more pressure in the cementing technique with risk of more leakage. And in 1998, the technique was described of the technique of kyphoplasty with less pressure, and with with less cement leakage. Until in the presentation, I have said I have seen patient with without kyphosis, without more kyphosis, to correct minimal wedge, and lately with the treatment of the tumors with the spine jack, and the technique also with cement technique with transpedicular screws to connect the anterior column, middle column to the posterior column transpedicularly with the screw. My question is, are you taking routinely a biopsy in all patients, or even not suspected to be tumors, to exclude other pathologies rather than the osteoporosis?
That's, that's a very good question. So those cases, if this is the first presentation of the patient with a mass in the MR, and even if the MR report looks like it is a metastasis, I usually have a pathologist in the room with me, and
Yes.
take the biopsy and wait until he tells me, go or not. Because a lot of times they can tell me, okay, I have cells, it looks malignant, I don't know what it is, so I go ahead and treat. Sometimes they tell me, I don't have malignant cells, so at that point I'll stop. Absolutely. Okay. Now there is cases that that the patient had lung mass or lung tumor and have an L1 metastasis that was treated, and have another T12, and then now you're doing L3, a new lesion. In those cases, probably I wouldn't be very, anal about it, because it's very unlikely that they have another tumor. But definitely no cement, no RF without diagnosis.
I am meaning in the cases of mostly suspected pathological osteoporotic fracture without tumors. It is a recommendation to take a biopsy in such patient to be the first diagnosis of multiple myeloma or of plasma.
Yes, you're absolutely right. So usually what happens is, if you have a patient who is osteoporotic and you have a history of trauma that tell you, I was carrying this heavy thing in my backyard and I felt the pain and they found the fracture, she doesn't have history of anything like any cancer, most of the time we wouldn't do a biopsy as a routine. However, having said that, when I have a male patient, and even if presented with a good history of trauma or fracture, still I will do the biopsy, because I know osteoporosis is not common in male like female. So I would like to be the one who first diagnose that. If the patient have any history of malignancy, even 20 years before, still I will do a biopsy.
Okay. Another question about the type of cement are you using?
Yes.
Polymethyl acrylate, also BMMA, or the?
Yes, that's the only one approved in the United States. So we can't use anything else.
Because in cases, for example, of cases of hemangiomas, active hemangiomas treated with cement, there are some people recommending to use active bioactive cement with hydroxyapatite or with calcium triphosphate.
Yes. If I have something to be done on myself, I would love to do one of those cements, but we don't have them in the United States.
Okay.
You guys are.
Thank you very much.
Yeah, sure.
Thank you, Dr. Hamdan, for your comments. Dr. Hussam Al-Nu'mani, Professor Hussam Al-Nu'mani, kindly unmute yourself and deliver your comment.
Thank you, Dr. Mohammed. First, I want to congratulate you and Professor Yusra Hawari for this magnificent series of webinars and all the eminent guests. Again, I want to thank Dr. Basim for his nice presentation. Actually, I have a couple questions for him. First one, do you think the going early after trauma, in cases of trauma, of course, after trauma with third vertebroplasty implants will give us much better results than going late, as you discussed in most of your cases. What I mean, if you go with the your technique just after the trauma by 1 or 2 days, is it going good more in the results or no? This is one. Number two is the do you experience it before the failure of hydraulic system in OsseoFX or in spine jack before or no? Thank you.
Okay, so the first your first question, I really don't know the answer because we still don't have enough experience, and the more we know, the better we will understand. Now I can tell you treating fractures in the first and second day is usually tricky because there is always, my experience at least, there is always a lot of blood, and there is a big hematoma going on there, but still, you know, you still can do it percutaneously. My gut feeling is probably with a spine jack, we may end up doing some kind of hybrid treatment of 1 level above and 1 level below fusion instead of 2 level above and 2 level below for the straightforward case. I have a feeling that adding the spine jack may be the reason to have your fusion a little bit shorter or smaller, especially if you're doing something like an MVA for a patient who is 25-year-old or 30, young patient that you don't want to do a big fusion for him. So that's my gut feeling. I don't know if this will be what we will end up doing, or we will end up doing only spine jack. Maybe it depends on the degree of compression, if the bone is osteoporotic or not. There is a lot of factors, so I don't know. But this is just something that I'm showing you what we're trying to do from our point here. In terms of the technical failure, I don't remember. I had one case, I did about probably 50 or 60 spine jack. I had one case where the bone was very hard that I couldn't open the spine jack. So I tried to open it, it didn't open. And then when I pulled the access device, just the whole spine jack came out because it was never opened. So this is the only case that I have a technical failure in.
Okay, thank you.
Thank you, Professor Hussein, for your nice comments. Dr. Isam Mardini. Dr. Isam Mardini.
Yeah, good evening, everybody. Thank you for this nice webinar. Actually, I have a question, the same subjects now. Some patient, I noticed from the presentation that the patient you presented, you did after 6 months. But some patient, we find difficulty if we stay longer to reduce and open the compressed fracture. So in that case, I just put the cement and go out. The pain reduce a lot, but actually it doesn't show any change on the X-ray. My question is: there any time that you should not go further to do the compression? Thank you.
Okay. Yeah. So you know, we have some rules that we have to follow in the United States. For your regular compression fracture for older population, 70, 80, 90-year-old, Medicare does not approve compression vertebroplasty or kyphoplasty if it is done before 4 weeks of conservative treatment. So the patient has to try conservative treatment first and failed conservative treatment before doing a vertebroplasty for compression fracture. That excludes patients who are in severe pain that actually, basically they show up in the ER that you cannot send them home because they are in severe pain and you have to do it inpatient to get them out of the hospital. Now, for the younger patient, the 40s or early 50s, we are in general, like you can call, I mean, there is no written guidelines, but we usually think about it that the patient is young, probably not osteoporotic. Why jump on and do something early? We usually like to wait around 6 months to make sure that the fracture is not healing by itself and the patient still have pain before we do anything. Of course, waiting make it much harder, but also I think it's reasonable, you know, to treat it as any fracture in the body, and we see all the time fracture that the patient had and healed over time and didn't need any surgery or any vertebroplasty. So we usually like to wait these 6 months for patients who are like in the early 40s, late 40s, early 50s.
Thank you, Dr. Bassam, for your comments regarding the extension of indication in post-traumatic fractures. Is the use of spine jack, for example, in cases with retropulsed fragment, can increase the displacement and can cause neural compromise? Is it possible or not?
You know, I had a case, but I couldn't find it to show it to you. But they are talking in Europe about what they call it ligamentotaxis, which is basically if the posterior longitudinal ligament is intact, once you raise the end plate, the fragment will be pushed back forward. I have seen cases like that. So I haven't seen a case where the fragment will be pushed backward into the spinal canal. Now, remember that two things. To make sure that the posterior longitudinal ligament is intact in MR is very hard to tell. Number two, we all do the procedures with local anesthesia. So if anything happened like that during the procedure, the patient will tell you. We don't do it with general anesthesia. But I haven't seen a case that the fragment went backward. But there is cases where the fragment moved anterior.
Okay, great. Regarding, there is another question from our colleague Kowiski. Do you use osteoporotic fracture classification, which is proposed by the German Spine Society for osteoporotic vertebral fractures or not?
No, I'm not aware of that. We're using any.
You are not aware of this classification.
Yeah,
okay.
Yeah. I don't
Great.
think we use specific classification for osteoporotic fractures. Yeah.
Okay, Professor Maziad. You have another comment, Professor Maziad?
Yes, that's just a question to Professor Bassam. Now we extended, or you have extended the indication of this intervention, minimally invasive, and lifting up the end plate to affect or to go through the traumatic cases. And you have mentioned that the patient, if it is young and 25, 30 years, still we have a chance to do this technique to lift up the end plate and restore the vertebral height, and that is good. And this has the benefit of reducing the segment, the motion segment, which have to be fixed. So this is good technique. But at the same time, you have mentioned that the FDA or the Medicare, you said Medicare, not FDA, Medicare will not approve using your technique except after 6 months after failure of the conservative treatment. So I will not get the benefit of doing the fixation as early as I can to reduce the fracture, while I need it to be accepted in application after 6 months according to the Medicare. And the other point which I would like to raise up, is it possible to use bone substitutes or hydroxyapatite or something which stimulate bone fusion, bone healing, rather than the cement in the young surgeon, in the young age group, because we prefer something to be used to be fused in the future, not to be like a foreign body and very hard and stiff, can precipitate adjacent segment, especially if we combined internal fixation from behind, posterior, and you would like to have something to heal, not to put a cement in young age. So would you like, please, to explain this point?
Okay.
Thank you.
So the Medicare guidelines are for osteoporotic fractures, not for traumatic fractures.
Fine,
So
that is clear.
yeah, this is the completely different set of patients, because the traumatic fracture is a young patient, had an accident, admitted to the hospital. He may have the fracture,
Yes.
have other stuff. So that doesn't interfere with it. Now, for the bone stimulating factors or cement, we have only one type of cement that's approved in the United States called Cortez, and nobody uses it because it's very hard to use technically, because it's very liquid and they leak in every place. And Europe has multiple bone cements that we don't have it here. And no company wants to try to get it into the United States, because you're talking about a 2-year process, probably $5 million or more cost of a study. So we don't have it. I mean, it's a great idea, but we don't have it to use. We can't use it.
Okay, thank you, Dr. Przemysław Kulakowski. Can you tell us what is your comment regarding the published classification in the Global Spine Society, Global Spine Journal, Dr. Kulakowski?
Can you hear me?
Yes.
Yes.
Yeah, I just wanted to mention that there were 2 publications in the Global Spine Journal in 2018, and it's done by the German Society for Orthopedics and Trauma Surgeons. One is a classification of osteoporotic thoracolumbar spine fractures, and the second article is done by the same group, and it's a non-surgical and surgical management of the osteoporotic vertebral body fractures. It's an open access articles, so you can look at them, and I think they are very useful.
Okay, I will look at them. Yeah. Global Spine Journal.
Global Spine Journal, yes.
Okay.
It's an AO Spine journal.
Okay.
Okay. Thank you, Dr. Przemysław. Dr.
You're
Hamdan
welcome.
Abdurrahman. Dr. Hamdan Abdurrahman, kindly unmute yourself and deliver your comment.
Hello, assalamu alaikum.
Alaikum assalam.
There is a OF classification score for the treatment of osteoporotic fracture. According to the score, including the fracture classification, OF 1 to type 5, bone mineral density also included, the pain score, VAS score, neurological deficit, the mobilization of the patient, and the general health of the patient. And we collect the points, 0 to 5 non-surgical treatment, 6 point non-surgical or surgical, and more than 6 point indication for surgical treatment. As the colleagues have mentioned 2 publications in the Global Spine Journal by the German Spine Society the first author was Schnacke, and he published this with the German Spine Group.
Okay, I'm not familiar with them. I will look at them and I will look at them for sure.
I have a small question. Yes. About infection after vertebroplasty and kyphoplasty have been published. I have published a paper in the Spine Journal in 2014 when the infection rate was 0.46. Are you have any patient with spinal infection after spine jack surgeries?
No, I am not aware of any case.
Okay.
Thank you, Hamdan, for your comments. And may I ask you to prepare a presentation regarding this classification, and you can conclude these two papers, and you can be our faculty in one of the journal club, Egyptian Spine Society Study Group journal
Thank
club, and be ready with your presentation.
Thank you very
Hamdan.
much. Thank you very much.
So we don't have more questions, Dr. Bassem. Maybe I will deliver the last question to you regarding the bleeding tendency. Before doing the vertebroplasty or these third generation implants, you need to check the patient bleeding tendency, and if the patient is on low molecular weight heparin, or if the patient on Plavix antiplatelets. So how you manage these? Can you give us some tips regarding these medications, when to stop, and how to avoid disastrous complication like bleeding during introduction of the needles and so on?
So the spine jack is actually a much bigger access device. I think it's 6 gauge or 8 gauge. So it's much bigger than your usual vertebroplasty needle. So we stop aspirin for 5 days. We stop Coumadin or warfarin for 5 days. We stop Plavix for 3 to 5 days. And we have a list of all the anticoagulants that the patients can take, and we just check them, make sure each one have their own time that we stop. Usually it's between 3 and 5 days. So my rule is always like 5 days, because it's much easier to remember. So if the patient had any one of those, we make sure that the INR is less than 1.5. So this is the guidelines that we go with.
Okay, thank you very much. So we don't have more questions and no comments. So Professor Yusri, there is no microphone in front of you, Professor Yusri. Maybe Dr. Yusri is offline right now. Maybe he has some problems in the internet connection. So at the end of this webinar, I'd like to thank Professor Dr. Bassem Georgi for his nice talk and highlighting the third generation vertebroplasty implants and the importance of properly choose your patients, and in patients with tumors or metastases, the importance of use something to create the void by the use of radio frequency before applying these implants or applying the cement. Thank you, Dr. Bassem. Thank you for being a part and a faculty in the aging spine. Every year you are here with us in January, and in this COVID-19 and the presence of this webinar, you are here again. And we are happy to hear from you every now and then regarding your nice presentations in the management of osteoporotic vertebral fractures, the tumors, and everything. Thank you, Dr. Bassem, and happy Eid.
Thank you. كل سنة وانتم طيبين.
وحضرتك طيب. شكرا جزيلا للحضور جميعا. Thank you everyone, and kindly I remind you to renew your AO Spine membership and kindly apply for the fellowship if you are candidate for it. It will help you a lot in fine-tuning your experience, and don't forget, stay safe, and see you inshallah in the next webinars. السلام عليكم ورحمة الله وبركاته. مع السلامة دكتور باسم. مع السلامة.